Dr. Bongo is a consultant ophthalmologist and also a vitreoretinal surgeon, currently working at the Aga Khan University Hospital. He is a clinical assistant professor and the section head in the ophthalmology unit there under the Department of Surgery. Dr. Bongo has got a lot of interest in anti-VEGF. I know he has presented severally about the role of anti-VEGF in management of diabetic retinopathy. But today his talk is on, is it just only about anti-VEGF? That is the talk for today. One of his hobbies is singing. If you have a birthday party and you want a song in French, a happy birthday, he can easily do that without a fee, of course. So welcome, Dr. Bongo. We are happy to have you today for this presentation. Asante.
Thank you. Thank you very much, Dr. Nyaga, for that those nice words. And this is a privilege to be with you today as a moderator of these presentations. Allow me just to share my screen. Good evening, everybody. As Dr. Nyaga have said, my topic today is it only about anti-VEGF? We know that anti-VEGF is a gold standard treatment for diabetic macular edema. But when I trained in ophthalmology, when I completed in ophthalmology in 2005, we did not know about intravitreal injection of anti-VEGF. But now the anti-VEGF are taken over central laser. And our question today, is it going to take over pan-retinal laser photocoagulations? And does it make a sense to use anti-VEGF also in treatment of non-proliferative diabetic retinopathy? And before that, is anti-VEGF 100% successful in management of diabetic macular edema? Every one of us have his story and he can share it today. The other question is, what is it about steroid? We continue to use steroid in the treatment of macular edema? And does central laser still have an indications? Can we have something better than anti-VEGF? Then what is vascular endothelial growth factors, VEGF? Do we need to know more about it? Those are the questions that we are going to try to answer during these presentations, and that's going to, I hope, will attract more discussions and questions because they are very open. So as I say at the beginning, anti-VEGF are nowadays a gold standard treatment for diabetic macular edema, and there is no doubt about it. It will be considered as a malpractice then to start with Grid-Argon Laser today as a first option if someone wants to have a good functional vision. Grid laser, however, still indicated when you use a micropulse laser, with still an indication for mild to moderate macular edema, because in advanced macular edema, micropulse laser is not sufficient to get a good outcome. But if we have to say that there is one indication of central laser using the traditional argon laser, the only indications that is the first options is when you have a succinate exudate away from the fovea. Successful clinical trial has started already when it comes to the treatment of proliferative diabetic retinopathy with anti-VEGF, something that we did not know before. What is the reason? Is because our traditional PRP has an impact on the visual field. It also has an impact on the contrast visions. That is why the tendency for the shift to anti-VEGF. But still there is a problem. As we know, when you go for anti-VEGF, you have to repeat the injections. That is why the expectation to promote anti-VEGF instead of pan-retinal photocoagulation for proliferative diabetic retinopathy is on acting, long-acting anti-VEGF. One of the examples is Bevocizulimab for Novartis, which is ongoing, and there are also many other molecules that are on trial. The role of anti-VEGF, if we have to summarize from the studies that are going on, even in the absence of diabetic macular edema, is expanding. For the treatment of proliferative diabetic retinopathy, anti-VEGF is a valid option, although it requires compliance. And we know that that is one of the main problems that we have with our patients when it comes to treatment of macular edema. However, so far, PRP remains the main armamentarium for treatment of diabetic macular edema, for proliferative diabetic maculopathy. Anti-VEGF in the treatment of non-proliferative diabetic retinopathy is something new. And if it happens, it will going to be a paradigm shift for what we used to have before as a practice. When you have a non-proliferative diabetic retinopathy, you have to observe, have a close follow-up, so that when there is neovascularization, that is the time you go for pan-retinal photocoagulation. And I can recall here one day, Dr. Kibatal, I don't know why he's following these presentations. One day during his presentation, he said, why don't we just get rid of the vitreous? Because that is finally what is the reason of all problems for diabetic patients, because particularly because of the tractional retinal detachment. And I think it makes sense to continue thinking in that direction. Everything starts by questioning. That is how philosophy is at the base of every sciences. So there's still a lot to learn for the research that are going on, but as per now, it should be a personalized decisions depending on the environment and the education of the patient. So is anti-VEGF 100% successful? I think I don't need to answer that question because all of us, we know that it is not, unless there are studies that are done by the pharmaceutical laboratories that are promoting, because they do on the selected patients, then you can say 100%, meaning that there's still a challenge with use of anti-VEGF. For example, this the GRCS network study that was done in 2016, it has shown that after 2 years, 41% of the patient needed to have a focal laser or central laser, 52% for the second group, and 64% for the third group. The third group being a patient on Avastin, the second one on Lucentis, and the first one on Aflibercept. In addition, there is risk during the use of anti-VEGF. We know that, and it needs to be identified and addressed. So why management of diabetic retinopathy is still a challenge despite the progress with the use of anti-VEGF? To try to understand the challenge, it will be important for us to come back to angiogenesis and VEGF. Angiogenesis from the Greek origin, angions, meaning vessel, and the formation of blood vessel from existing vasculatures, which is a process that involves the migrations and broad differentiations of endothelial cell with line inside the wall of the blood vessels. And in our case here for diabetic retinopathy are the retinal vessels, the capillary. And the process of angiogenesis is controlled by chemical signal in the body. And that is important to know. Those chemical signal, and here it put in plural, because there are many. VEGF originally was known as vascular permeability factors. It enables us to understand why the same growth factors is involved in neovascularization and at the same time in macular edema, because it have both the impact on neovascularizations and on macular edema because of the first property of vascular endothelial growth factors that was discovered. And basically is VEGF is a subfamily of growth factors, and there are many growth factors, and it is involved in both vasculogenesis and angiogenesis. The difference with vasculogenesis and angiogenesis is that vasculogenesis is during embryonal period where there is no vessels, but angiogenesis is the formation of new vessel from the existing vessel. Angiogenesis is part of the system that restores the oxygen supply to tissue when there is hypoxia. That is why the concentration of VEGF is high for people who have bronchial asthma and diabetes mellitus. The function of the VEGF is to create new blood vessel, as I say, already during embryonic development, but also after injury, muscle following exercise, and collateral circulation to bypass blocked vessels. And that's what we have mostly when there is a retinal vein occlusions. But the problem is that it can also contribute to disease. And that is why we have a diabetic retinopathy, but not only diabetic retinopathy, but we have cancers that are involved and many other systemic disease. And that is why pharmaceutical companies have come with treatments, as we know, as anti-VEGF, particularly Aflibercept, Bevocizulimab, and Ranibuzimab, that act against the VEGF. This table just summarizes the different family of anti-VEGF, of VEGF, vascular endothelial growth factors. You can realize that when we talk only about anti-VEGF, it's somehow an abuse of language, because we should say anti-VEGF-A, because there are different types of VEGF with different functions. And the end result of the action of VEGF is to obtain a tube formation and a survival of new vessels. It is also one of the most potent permeability factors, as I said, because VEGF-A is a common link of inflammation and permeability and angiogenesis. I put on my first slide, what about steroids? But when you look at the angiogenesis of formation of new vessel, then you will understand, because of the vascular endothelial growth factors, that steroids still have a place in the pathology of the diabetic retinopathy because of that link between inflammation, permeability, and angiogenesis. So everything starts with hypoxia. And we know that hypoxia in diabetic retinopathy is caused by hyperglycemia. So when there is hypoxia, then there is a HIF, not NHIF, 1 and alpha and beta. They are the one that induce the production of vascular endothelial growth factor A. And the circulating VEGF then has a receptors on endothelial cells that's going to trigger a tyrosine kinase pathway leading to angiogenesis. And I would like you to remember here tyrosine kinase pathway, because at the end of it, we are going to come back to it. Just as a summary to see all the process of angiogenesis with this circle here that I have it thanks to my daughter. To show the beginning with when an endothelial cell is activated by lack of oxygen, then there is a release of angiogenic molecule. And those angiogenic molecules that you have the VEGF and you have the tyrosine kinase that I talk about it, that are going to attract inflammatory cell, endothelial cell, and promote their proliferations. And then during that, the migrations of those endothelial cell and inflammatory cells, there are secretions of endothelial cells that are going to lead to differentiation and secretion of metalloprotease, which digest the blood vessel wall and cause the endothelial cell migration, and at the end result, anastomosis and formation of capillary. You can see how complex is the process. It's not only VEGF, but there are a series of reactions that are going to happen before formation of blood vessel. And that is a normal process of angiogenesis when there is no disease. In this second diagram, for pathological process of angiogenesis, you end up having destabilizations of the new vessels and neovascularizations, because in actions come the pathway of the tyrosine kinase that you are going to come back to it, and other angiogenic molecules that happen when someone have a long-standing hyperglycemia and hypoxia. Just this figure to show how macular edema occur during the process of angiogenesis through the disruptions. And here you have the normal endothelial cells on top. At the middle, when there is inflammations, when there is a pathological angiogenesis, and at the third one, you found in the case of cancer. And this diagram just to remind us to understand why, for example, drugs like Avastin that was used for the treatment of cancer found himself in the eye, because the pathogenesis of the pathophysiology of all those conditions has the same mechanism, because it involves the vascular growth factors. Just to say that physiological angiogenesis is a normal situation every day in the body, but pathological angiogenesis occur in particular circumstances. And it's not only about diabetes, as I said at the beginning, over 20 diseases, this process, pathological angiogenesis are involved. So, as I presented in the first diagrams, I mentioned the tyrosine kinase. And from the tyrosine kinase, which is involved which is involved in the normal angiogenesis, and the same in pathological angiogenesis. I come back to that diagram to show you here at which level it occurs, because the VEGF, they have as a receptor also the tyrosine kinase, and that pathways of tyrosine kinase are a kind of pathway regulators of angiogenesis in normal circumstances. When it's come to the Ty2 pathway, because there is also a Ty1, all those are proteins that are a binding partner of the tyrosine kinase. You have other molecules that are involved and that are also protein. It's angiopoietin 1 and angiopoietin 2, which are the Ty2 binding partner. And without Ty2, or what I call in abbreviation Ang-1 and Ang-2, vascular development is abnormal. There are a couple of regulators that are different from the VEGF pathway. The first class with Ang-1 and Ang-2, and the second class with an intracellular enzyme that is called Vascular Endothelial Protein Tyrosine Phosphatase. I will call it VE-PTP. So in the retina, when Ty2 is activated, there is a control of endothelial cell proliferation, control of barrier function, and intercellular contact. That is why in the physiological angiogenesis, you can have a formation of new vessel without having neovascularizations, mostly because of this pathway of the Ty2. And you can't have you cannot have edema because it is this pathway that is responsible for the stabilizing vessel and blood retinal barrier. As we know, we have the inner blood retinal barrier and the outer retinal barriers. In order for the vascular endothelium to be stimulated by the VEGF, the Ty2 has to be downregulated, meaning that the Ty2, this pathway acts as the rheostat that controls the endothelial cell with response to other stimulating factors. And to help us to understand and why we are talking about the Ang-1, which is the agonist for Ty2, and the Ang-2, because they are responsible for the phosphorylation of Ty2 that ultimately lead to the vascular stability. Just with diagram, it will be easy for us to understand. Here you have Ty2, as I say, which is the regulators of the angiogenesis or the formation of new vessels. So when there is Ang-1 at a normal level in the blood, there is vascular stability. In the other hand, Ang-2, I will tell later on why this place minus, inhibits the vascular stability, meaning that it causes vascular destabilizations. If we put it in a simple word, Ang-1 causes Ty2 activation and Ang-2 inhibit Ty2 activations, meaning that if Ang-2 inhibit Ty2 activations, is going to be vascular destabilization, and we see the clinical application with diabetes. In addition to Ang-2, which is responsible of vascular destabilization, we have what I mentioned before as the VE-PTP, which is a vascular endothelial protein tyrosine phosphate, who can deactivate type 2 and destabilize vascular endothelial cells. So we remember here that we have two other angiogenic molecules, Ang-2 and VE-PTP, who can destabilize the formation of vessel in the body. So this is what happened in hypoxia. To understand the clinical applications of this pathway, when there is hypoxia and related to hyperglycemia, that is why the interest of presentation of this pathway, the level of Ang-2 increases, and at the same time, the level of VE-PTP increases the same, meaning that there is deactivation of type 2 as a consequence, vascular destabilizations, meaning we are going to lead to disruptions of the permeability at the level of the endothelium, inner retinal barrier and outer retinal barrier, and at the same time, we are going to have neovascularizations. So, however, in order for Ang-2 inhibition to succeed, Ang-1 is necessary actually to bind to type 2 receptors. But in contrast, blocking VE-PTP alone, irrespective of level of Ang-1, we are going to have a result. Why are we talking about Ang-1 here? Because the problem is that when Ang-2 and VE-PTP increases in diabetes, in contrary, Ang-1 decreases. That is why when there is a clinical application only involving Ang-2, there will still be limitations. Just a summary of what I've just said. So in conditions such as diabetic retinopathy and also age-related macular degeneration where hypoxia is important, VE-PTP is upregulated continuously and is active enough, it will be impossible to overcome it by extracellular agonists. And that is why this scenario, the role of the VE-PTP explain why we cannot have with anti-VEGF 100% success, because they will be the hypoxia will be always there in diabetic patients, so there will be always a production of VE-PTP, and that is one of the reasons why we have to repeat injection of anti-VEGF. So the type 2 pathway seems to be involved in the pathophysiology of diabetic retinopathies at every stage. And hyperglycemia going to cause upregulation of Ang-2. And we know that Ang-2 has been implicated in pericyte of the endothelium vessel apoptosis, which explain all the complications related to diabetes. So as the disease progresses and Ang-2 increases, VTP, as they say, is going to destabilize the vasculatures and increase its responsiveness to VEGF. So VEGF promotes leakage and then neovascularization, as we know. So the ability to modulate, that is the conclusion of the clinical implications, is that the ability to modulate this pathway pharmacologically has a huge potential for diabetic retinopathy and diabetic macular edema, and a potential for neovascularization in age-related macular edema, as they say, because of the control of the VE-PTP. So far with the trials that are in progress, as we know, what is very crucial as a measure of success are three components. If the drug is safe, if it is efficient, if it is durable. And so far with experience going on, the safety for the clinical applications of the type 2 pathway is better than anti-VEGF. And also in terms of efficiency, because in addition to the treatment of diabetic retinopathy, it has a systemic benefit for diabetic. And also in terms of durability, remember that I said for us to shift for pan-retinal photocoagulation PRP to anti-VEGF, there is a problem because of the repetitions of the injection for intravitreal. But with the experience so far with those of the clinical application of type 2 pathway, there is extent of the durability such that it can lead to quarterly injection or even more than that. And the most of it, there is even a possibility of a systemic injection without going intravitreal. So as a take-home message for, if you ask me for these presentations, I can say that there is already a paradigm shift for management of diabetic macular edema. And there are ongoing paradigm shift for proliferative diabetic retinopathy and non-proliferative diabetic retinopathy, which is something new. And it's still many challenges because of the pathogenesis of diabetic retinopathy, which is very complex, as you have seen, that I've tried to go quickly through those slides. But focal laser, PRP, steroid, vitrectomy, I did not talk about it because you will find a lot of amount of vascular endothelial growth factor in vitreous when someone has diabetes. They still have a specific indications. And I can say that the future is brighter through the clinical application of the type 2 pathway. Is it going to be a revolution? We don't know yet, but it may be. Thank you.
Thank you very much, Dr. Mbongo, for your nice presentation. We will be able to get responses from questions and answer questions which members may have. And can you see any questions posted already? Because we want to have a response to the questions posted.
We don't have yet, so we can have them live if someone has it as we wait for those who are posting their questions.
Can we have somebody either making a comment or a question? You can unmute yourself and introduce yourself and be able to register your, oh, there we are. There's a question from Dr. Shafiq, Dr. Jafeji. Sorry. And Dr. Jafeji is asking, are there any drugs being developed towards these pathways?
Yeah, currently Roche has developed a product that is based on Ang-2. I think they are ongoing. I think they are going to meet. They are going to meet us soon to give a presentation. But it based on this type 2 pathway because they were involved in the study at the beginning. Novartis still ongoing, and which company? Yeah, even Aflibercept. What is the company with Aflibercept? Someone can remind me. They are still also involved in the research, but so far in the market, not yet. But hopefully, with Roche here in Kenya, we are likely to have a product which is related to it.
Thank you, Dr. Mbongo. There is a question from Dr. Oscar Onyango. He makes a comment. Thanks for the presentation. Any role for protein kinase C pathway inhibition in diabetic retinopathy?
All those products that are going to thank for those questions. First, I forgot to say, all those products that are going to come from the clinical implications of the type 2 pathway are going to be related to the tyrosine kinase, because they are from the regulators of the stability of the vessel. That is, a new finding is based on the tyrosine kinase. That is why we are not going to have a product anti-tyrosine kinase, but they are going to apply according to the involvement of the tyrosine kinase to the type 2 pathway. And even the one that Roche has developed is going to be in the same direction.
Thank you, Dr. Mbongo. We have a question from Amos Kibatal. Muchai has been doing sub-threshold grid laser for macular edema at CTI. And he's wondering who else is doing sub-threshold laser and what has been their experience.
Can
you have some comments? Anybody who is doing sub-threshold laser? Shafiq, are you doing?
Hello, Dr. Ari, how are you?
Fine, thank you.
Thank you for that wonderful presentation, Dr. Mbongo. Actually, I'm not doing sub-threshold laser, but I understand Dr. Hatim is doing at Lions. They have an IDDEX machine, which is able to do sub-threshold laser. They call it, I think, I've forgotten the terminology which they use for that.
Thank you, Shafiq. Is Hatim logged in? If he is, maybe he can make a comment. Can anybody see Hatim in the meeting?
I have a feeling he's not logged in, Dr. Ari.
Okay.
Or Dr. Kibatal, if he can give a comment on what Musha is doing.
Amos, are you on?
I think Mushai would be the best person to say. We haven't done many numbers, but we're just beginning now to do more and more. And certainly, it doesn't seem to get worse. We haven't seen any adverse effects. But when you read the literature here and there are some very encouraging reports. Some of them sound almost too good to be true. So I guess we'll wait and see and build our numbers and see whether it actually makes sense. A lot of these people are people that we've injected and just almost given up. So we just do sub-threshold laser. And I think Bushai has got a few very good responses. But I think our numbers are still small. But it would be nice to know what others are doing. Because if it is true that you can get good responses with sub-threshold laser, then we are missing an incredible modality that will be so applicable in our setup. So I think it's just something we need to really explore and explore quickly so that we know whether this is a modality that applies to us and or doesn't apply to us. Bongo mentioned my incredible thoughts about removing vitreous, and now they're even more firm. I'm more convinced that that is the way to go. And I think one of these fine days we'll need to do a double-blind study, because the vitreous just seem to be the problem. But anyway, before we have data, I can only postulate.
I'm glad to hear that you can still take it up. That was my aim to to trigger that. I'm glad to hear that. Definitely.
Is Mushai logged in? He can comment about the subthreshold laser as well, now that he's doing that and her team is not in the meeting today.
I'm not seeing Mushai, so maybe we'll put that as a consideration for another CME perhaps, because I'm not seeing him logged in.
Yeah, it will be interesting to talk about it, because from some conference that I attended to, the most important criteria is that when the edema is reduced, in mild to moderate macular edema is efficient, but in advanced macular edema, then it doesn't work. That is why for some of the study, they start with anti-VEGF, and after the second years, when the edema is reduced, they now go for the micropulse, laser to maintain to control the macular edema, I want to say. But it'll be good to come back to it with our own experience here.
Okay, thank you. There's another question from Dr. Jaffeji. He comments that the steroids tend to address almost all the pathways. Does this mean we should shift to usage of steroids?
No, but because it's not only, of course, steroid does have its place, and that is why, for example, Ozurdex can give a good result and last longer than anti-VEGF. It has an advantage, but it cannot replace anti-VEGF, because it's a complex pathway that all the time you will still have. If you control with the inflammations, you will still have VEGF, you will still have those VE-PTPs that are going to continue to destabilize the vessel. So it needs a comprehensive management. But from my experience, there are some situations in diabetics with macular edema that using anti-VEGF is just wasting of time. Steroids do better. For example, patients with chronic macular edema and diabetes with chronic macular edema that are going for dialysis, I never had a good result with anti-VEGF, but with steroids, you get better results, even if it is not. It doesn't restore the sight of the patient to 100%, but you have better results. So steroid definitely have its place, but it cannot take place of anti-VEGF.
Yeah, thank you, Dr. Mbongo. There's still something else on that's a question from Frank about the low setting situation where patients cannot afford anti-VEGF and they are phakic or they are a bit old, and maybe other reasons as well. Can you advise for use of triamcinolone?
I will say yes. Instead of having argon grid laser, why? And my answer also be related to the age of the patients. If you have a patient who is 40-year-old that have a huge macular edema and you want to solve it with a argon grid laser, of course you'll be satisfied. The edema will reduce, will decrease, he will recover his sight. But if you see that patients 15 years later, 20 years later, the way I saw this last year, a lecturer for University of Nairobi that had a grid laser 18 years ago and have a good sight, but he has gone blind. What happened is because the scarring of the laser mark has increased, and now he's blind, and that is a lecture. So I will say it will be, I will take the risk to control by giving a triamcinolone, then to give a grid as a first option. Of course, if it is an elderly patient, his life expectancy is not much, then I might consider giving grid.
Okay, thank you very much, Dr. Mbongo. Now we have a question from Godfrey Nyaga. What is the take-home message for the young ophthalmologist in the periphery with a poorly controlled diabetes with PDR? If they do nothing, the patient will go bright. Intravitreal triamcinolone, maybe it's related to what you have answered, unless you have got something else you want to add.
Of course, as I said, intravitreal triamcinolone I will prefer according to the age of the patients, and at the same time that the advocacy of having a micropulse laser. I'm glad that Lions, they have it, City High, they have it. We have to go to the use of micropulse so that if you start with steroids, since we know that steroids have a side effect of glaucoma, when the edema is reduced, you can easily continue controlling the macular edema with a micropulse laser. For me, before we have the development of the new drugs that are the clinical application of type 2, I will advise that.
Thank you very much, Dr. Mbongo. There's a new question which is coming in.
Yeah.
Sorry, Dr. Karu, continue.
There's a question from Sami Langat to a great presentation. That's what he says. What is the affordability with these patients in the anatomical follow-up with OCT? It plays a big role with what I have seen elsewhere and for differentials when anti-VEGF aren't working. So I don't know what you get to say on that.
I will leave that question open to all the vitreoretinal that are in the panel here. If someone wants to answer about OCT, cost implication of OCT in the management of diabetic retinopathy, if I've understood that question.
Amos, are you still there?
Yeah. Okay, I had a different comment. The question is, what is the affordability with these patients in the anatomical follow-up with OCT? Okay, one, I want to make a comment on triamcinolone, because triamcinolone is so easily available and so cheap. But my experience has been that in very, very severe macular edema, when you dry it up quickly with triamcinolone, you get crystalline deposits at the fovea. You get a, I don't know what it is. I don't know whether it's exudate. I don't know what it is, but it's a shiny, solid deposit at the fovea that, and once you get it, you're done. That thing never goes. The vision, you get a catastrophic fall, and it never improves. And it was so common that I actually now stopped giving triamcinolone for very, very severe macular edema. I would give anti-VEGFs, Avastin, that reduce the edema a bit, then I can finish off with triamcinolone. And I would like to know whether Jaffaji and the others have the same experience. So, and if once you get that thing, you're done. That's finished. That thing never goes. The vision, the patient completely loses their sight. So I would be cautious with triamcinolone in very, very severe macular edema. The other thing is that a lot of these severe non-responsive macular edemas are ischemic. And whatever you do, it just doesn't, it doesn't improve. And so I only wish we could be able to have, either OCTAs or angiographs, because then you can differentiate who will benefit and who will not benefit. Because we inject a lot of people, and a significant amount of them, nothing happens. For me, as the role of OCTs, I think if you don't have an OCT, then you are lost. You have no clue whether you're making progress, whether it's getting worse. It's just unfortunate, but I can't see how you can treat macular edema effectively without an OCT. You can use vision, and there was a study, some studies on AMD. The earliest studies on AMD actually just used vision as a surrogate marker of when to inject or not to inject, but you really need an OCT to treat macular edema. I can't see how how will you decide when to stop, when to start, when to continue? Without an OCT is impossible. Yeah.
Dr.
Advocacy at the country levels. Now their country, their budgets, then we need to do advocacy to have OCT at least in the main hospital.
Maybe,
comment.
And I will, at the risk of being controversial, I think the route of advocacy will not go anywhere. I think people need to get together and buy an OCT, and send all the patients there. It sounds weird, but the guys in Thika have done that. They have an OCT now in Thika. So all the patients in Thika now have an OCT. The patients in Moranga have an OCT, and they're able to manage. So it's both a problem, but it's also a business opportunity. I mean, I worked in Cape Town, and Dr. Nyaga knows. And in Cape Town, there's a big, very good eye center that is owned by about, I think there were 10 or 12 ophthalmologists.
18.
Who decided there's no need of all of them owning theaters. So they all came together, they built the theater, and they all use it. So why can't several people come together, put an OCT somewhere centrally in the county somewhere, and all the patients are sent there, and at least you can manage. Now, this is not science, but just thinking out of the box.
By the way, it's a very good idea.
I think Dr. Kareko had raised her hand, so I don't know if she has a message or she wanted to contribute to the discussion. Then we can have Dr. Shafiq Jafaji, if Kareko is not.
Right. May I comment?
Yes, please.
Those are great comments coming from Dr. Kibatal, and definitely we should all take it up. Just to add on regarding the question of affordability versus OCT, the idea is to treat the patient, yeah, and not only the OCT. So it is not only one thing that we are looking at. We are looking at vision, we are looking at that patient, we are seeing where he's coming from, we are seeing the OCT findings. So it's all of it that you look at and you treat the patient. Yeah, so not only trying to get that OCT dried out. That's one thing. The second thing is there are whole lectures on OCT findings, which will give us guidelines on whether to continue treating a patient, whether to stop. See, like the size of a cyst, the height of a cyst, ellipsoid formations, yeah, what kind of pillars are there, what is happening at the photoreceptor level. All these things are to be interpreted. And just as Dr. Kibatal said, there are some retinas which are just ischemic, and at times we are busy trying to bring the vision up and right up, but It's an ischemic retina, and it's done. The third thing was, Dr. Kibatal asked about the crystalline formation versus usage of triamcinolone in the diabetic macular edemas. Now, there is a conceptual thing that we need to understand, that in very severe diabetic macular edemas, the end stage is when you have the hard exudates accumulate at the fovea. That's the end stage of disease. Don't even try to treat it, as Dr. just said. Because what is happening is you've got leakages or microaneurysms all around the macula, which are leaking. And when they're leaking, they are leaking in a centrifugal manner. Yeah, the hard exudates are moving from the microaneurysm, moving out centrifugally. So if you have microaneurysms all around the fovea, the hard exudates are accumulating towards the fovea. And once you get a plaque which forms at the fovea, that's literally end stage of the disease. Whatever you throw in, the vision is not going to improve, definitely. And probably the crystalline formation that we get to see is those hard exudates accumulating at the fovea. So those were the few things that I wanted to comment on. One last thing, sorry, to add on, regarding the subthreshold laser. My personal feeling is probably that is the way to go eventually, because Iridex as a company were the first people to start micropulse laser. They called it MLT, and now they've started using it for trabeculoplasties. They've started using it for cyclophotocoagulation other than macular laser. And they are showing wonderful results. In fact, MLT, SLT, if I may just deviate a little bit, SLT, why it became popular is because of the repeatability. Now, MLT, micropulse laser, or the subthreshold laser, does the same thing. There is repeatability. You do it once, either in the trabecular meshwork or on the retina, and you can repeat it and you can repeat it. And there is no scarring involved with it. That's the beauty about it. Thank you very much.
Thank you.
Thank you very much, Shafiq. I think we may have to end the question and answer session, but before we do that, I would request Dr. Mbongo, in summary, to give a take-home message for today's talk, particularly for our young ophthalmologists who are in the group. Maybe have a minute or so, just take-home message.
What I will say is that the management of diabetic retinopathy has changed, starting with management of diabetic macular edema. Grid laser, and particularly with argon laser, is no longer the first options. Number two, there is a shift going on for management of proliferative diabetic retinopathy and non-proliferative diabetic retinopathy. And it is important to be aware of it, because when we started doing phaco here some years back, nobody could have think that today phaco is becoming the first option for the patients. It means whether we like it or not, patient will ask for it. So we have to know about it, prepare ourselves for it. Why not think about a vitrectomy also, or the possibility for young people to refer to the vitreoretinal surgeon, as the discussion has started today again with Dr. Kibatal. And we can say that there is hope. Maybe in the future, we will not even need to give intravitreal injection. We'll do subcutaneous injection for the new molecule that are on study. So let us keep reading and looking forward for the changes, and don't work alone. You have quite a number of vitreoretinal surgeons now there in Kenya, and particularly in Nairobi. You can always ask them questions and ask to work together with them. Thank you.
Thank you very much, Dr. Mbongo. I think before we end, we should have done this a little bit earlier. The chair of OSK is in the house, and we thought before our sponsors make a few comments on their product, I thought we would have Dr. Koril to do some housekeeping, give us a few remarks before we invite the sponsors, Novartis, to say something.
Thank you very much, Dr. Nyaga, Dr. Mbongo, wonderful presentation, and all people who participated. I don't have any much housekeeping today, just to say that we will be having twice a month CME. We'll be doing online CMEs at least the first quarter of this year, and then we'll revisit and assess depending on the situation. Thank you very much, Dr. Kalu, for moderating this. And thank you, Novartis, for sponsoring this particular event. Thank you.
Thank you very much, Dr. Koyo. I'll now hand over to Dr. Karu to invite the sponsors.
Thank you very much, Dr. Mbongo, Dr. Nyaga, for that wonderful presentation and question and answer session. Brenda from Novartis will have 5 minutes, and then we close the session for today.
Thank you so much.
Brenda, please.
Are you able to see my screen?
Yes.
Yes, we can.
Okay. Okay, thank you. So good evening, everyone. So very fast, I'll just share with you a very important study that has been done. And this is the rival study. So for a long time, no study had been done to actually compare the efficacy, and especially when it comes to vision outcomes, so visual outcomes, and also the injection loads when it comes to Ranibuzimab and Aflibercept. This is the first study of its own, and it is the rival study. And I would like all of us to walk into the light as we get to see the outcomes of this study and get to know more about the differences, if there is any difference when it comes to efficacy, as well as the loading injections. So before we get into the study itself, let's just have this. That was a brief video describing our patisiran. So I'll talk about it at the end of it. So back to the rival study. As I mentioned earlier, the study was done to majorly do a comparison between Ranibuzimab, which is our patisiran, and Aflibercept in terms of visual outcomes, and also in terms of the loading doses of the injections. So when it comes to the objectives, these are the objectives of the study. We had the primary objective, which was to investigate whether there was a difference in the development of macular atrophy between Ranibuzimab and Aflibercept when using the treat and extend regimen to treat the study eyes, which had neovascular age-related macular degeneration patients. And the key secondary objectives were to investigate the comparative efficacy outcomes of the treat and extend regimen between patisiran and Aflibercept for the NMB patients in terms of injections, and also in terms of the changes in the best corrected visual acuity from baseline to month 12. So the study design was as it appears. The study had 281 treatment naive patients. They were put on one arm was put on Ranibuzimab, and another arm was put on Aflibercept. It was 1:1. The ratio was 1:1, and the screening basically took place for a period of 2 weeks. And then we had the loading doses done between day 0, and then at the 4th week and at the 8th week. And then during the 52-week period, We had the 12 months interim analysis, and at the end of the 24 months or 2 years, the study was done with, and we will have to look together at what the results were. So at the end of year 1, the rival study actually showed that the patients who were on Patizra, these were the neovascular age-related macular degeneration patients who received Patizra, actually experienced a numerically greater mean best corrected visual acuity as compared to Aflibercept. And this is the presentation that is there on the graph. We can see patients who on Patizra had the advantage, numerical advantage of visual improvement by 7.2 as compared to Aflibercept that actually the patients got 4.8. And was this different by the second year? Not really. On the contrary, we can be able to see that by the end of the 2 years clinical trial, the patients who are receiving Patizra again experienced another numerical advantage when it comes to the mean letter gain at 6.6 as compared to Aflibercept who are at 4.6. What does this mean for our patients who would be on Patizra? This only means that the patients who present with AMD and receiving Patizra would be better placed because they will be able to benefit from unsurpassed efficacy as compared to Aflibercept. And when it comes to the distribution of treatment intervals that were achieved during the period of the 2 years or the 24 months, it was actually shown that similar proportions of patients who received both Patizra or Aflibercept were able to reach each treatment extension interval. And that is what we can clearly see from the graphical presentation. And what again does this mean for your patients who would be on Patizra? Rival study demonstrated that the durability of Patizra is unsurpassed by Aflibercept. And this is not all. When it comes to flexibility and durability, Patizra offers your patients what they need. So we find that Patizra offers durability for all neovascular age-related macular degeneration patients who respond well to the treatment and also who would need it for their frequent dosing. And when it comes to the flexibility of treatment, because of its treat and extend regimen, Patizra allows a 4-week treatment interval in MMD patients, and this is extendable by 2 weeks at a time, and even up to 12 weeks and beyond. And this, for your patients, it means that all your patients are covered for. So with all that we have discussed in those few minutes, this latest rival study results actually demonstrated more advantage of prescribing Patizra through the treat and extend regimen for all your AMD patients. So what confidence do we have with Patizra? We have the confidence of its powerful when it comes to, of it being powerful when it comes to efficacy. We have the advantage of it being precise, and we have the advantages of its efficacy, durability, and flexibility being proven. And this can give you the confidence that if you need an anti-VEGF, Patizra is what your patients need. Thank you. So the video actually showed us that we will be able to offer your NMD patients the same great efficacy, the safety that you know, and what comes more, it will come at an accessible price. Thank you.
Thank you, Brenda, for that presentation. And also, thank you for trying to keep time. So before we go off, I would like to once again thank Dr. Mbongo for such an enlightening presentation, and Dr. Nyaga for the moderation. Also, thank you for joining us, Dr. Kibatal, Jafaji, for all those comments and explanations. To remind us all, our next CME will be on the 11th of March this year. The topic and time will be shared with you on the group in due course. So thank you everyone for joining us, and hope you have a very good evening. Good night.
Thank you very much, Dr. Kalu.
Thank you, Dr.
Pleasure.
Karu.
Thank you, everyone.
Thank you very much.
Thank you. Thank you. Thank you all.
Thank you very much, Dr. Nyaga.
Please feel free to
Yeah,
leave.
Asante pia Mbongo, that was a very stimulating presentation. Thank you.
Karibu.
Bye.